Hello, you are most welcome, ladies and gentlemen, to the Understanding Spirit of Anatomy on Tuesday Night Anatomy with Daniel Okwan. Today's section, we continue with the revision exercise on the upper limb anatomy that we've already looked at. So please, if you've not got the opportunity, to watch those videos, they are in my playlists, visit it, and of course, get all those videos watched, so that you can get better understanding regarding this revision exercise. And so, without much ado, let's set the ball rolling, looking at the revision questions I have for you today. We begin with question number 1, and question number 1 says, which of the following is not true, of course, about the upper limb? Option A says the lateral third of the brachialis muscle is innervated by the radial nerve. Yes, of course, this is a very true statement. These are the questions that examiners like myself, we are interested in setting, because of course we know that the radial nerve will supply muscles of the posterior compartment of the arm as well as of course the forearm. But the interesting thing is that although the brachialis muscle is a muscle of the anterior compartment of the arm, and as expected, it's supposed to get that kind of motor supply from of course the musculocutaneous nerve, but surprisingly, the lateral third of the fibers of what we call the brachialis muscle will receive innervation from the radial nerve. So this option is actually a true statement. Now option B says the largest head of the triceps brachii muscle originates above the spiral groove. Yes, this is a wrong statement, because of course we know that the largest head of the triceps brachii muscle is of course the medial head, no problem. But it originates actually below the spiral groove, not above the spiral groove. We will justify these ones. So already we've seen our correct answer, because there's a wrong statement. That is option B. But let's move on and see the other things. Option C says the proximal part of the subclavian artery gives rise to the vertebral artery, thyrocervical trunk, and of course internal mammary artery. Yes, this is a very true statement. You see that the first part, yes, of course, with the help of the scalenus anterior muscle, yes, we're able to divide, of course, the subclavian artery for descriptive purposes into 3 parts: the proximal part, or the medial part, or that's the first part, and of course the second part of the deep part, the one behind, of course, the scalenus anterior muscle, and of course the one lateral to the scalenus anterior muscle. But of course we know that beyond the outer border of the first rib, it becomes what we call the axillary artery. Okay, so that's a very true statement. Let's move on. Now option D says the sensory supply to the nail bed of the index finger is obtained exclusively from the median nerve. That's a very true statement. We will justify these ones. So that's a true statement. In other words, if you want to actually remove the nail of the index finger, then the nerve which you are supposed to anesthetize will be a branch of this median nerve to the index finger. So that's a true statement. Now option E says the palmar and dorsal surfaces of the medial 1.5 digits of the hand are supplied exclusively by the ulnar nerve. That's a very true statement, because the ulnar nerve will give not only the palmar cutaneous branch, but also a dorsal cutaneous branch to supply this kind of medial 1.5 digits of the hand, as well as the palm and dorsal surfaces of the hand. So that's a true statement. So let's try and justify these options. So there we are. Yes, we know that if you look at the posterior compartment of the arm, that of course the triceps muscle, or the 3 hairs, the medial, lateral, and of course the long hairs, all receive innervation from this nerve, being the radial nerve. Yes, of course we know that in the posterior compartment of the arm, talk about the anconeus, extensor dictorum, talk about extensor carpi ulnaris, talk about extensor carpi radialis brevis and longus. Yes, all those ones. Talk about the spinator muscles, abductor, pollicis longus, and all that. All those muscles in the posterior compartment of what we call the forearm as well as the arm, will be getting their motor supply coming from the radial nerve. But the surprising thing, which of course you have to understand, is that the lateral aspect, this is the anterior compartment of the arm. We know they are supplied by the nerve which we call the musculocutaneous nerve, Yes, but what happens is that the lateral third, okay, of the fibers of the brachialis muscle will be receiving, motor supply from what we call the, radial nerve. So that's, an interesting thing that you have to know. Yeah, so looking at the origin of these, an insertion of these muscles. Yes, if you look at the radius, now if you look at this, taking an anterior view. Sorry, this is a posterior view because you can see the olecranon, fossa, and then because you can see, of course, both, the radial fossa as well as the, coronoid fossa, yes, at the distal aspect of what we call the humerus. Then we know we are looking at the posterior aspect. So if you look at it, then we know that, we have what we call the greater tubercle at the proximal end of the humerus, and we said that there will be 3 facets there, okay, which we have, SIT, yes, S, the superior facet will be the insertion point for what we call the supraspinatus muscle, yes, I for infraspinatus muscle, and of course, T for teres minor muscles. Yes, all these muscles are muscles, we call them rotator cuff muscles, 3 of those muscles, okay, or the steering muscles. Now the 4th muscle, which you call it, the subscapularis muscle, rather inserts on what we call the lesser tubercle of the humerus. Okay, so that is what you have to actually know. Now, if you look at, between the greater and of course lesser tubercles, there is a sulcus, or there is a groove, which of course we call the intertubercular sulcus or the bicipital sulcus, because of course the tendon of the long head of the bicep brachii muscle together with its tendon sheath, will run here. That's why we call it bicipital, groove. So over there is would be 3 muscles which are going to insert there, and there's a simple mnemonic for it. Of course, a lady between 2 majors. Yes, of course. So the major, okay, to the lateral aspect, the lateral lip will be the insertion point for pectoralis major, and then of course, and the major, okay, to the medial aspect, medial lip of what we call, the intertubercular sulcus will be for, teres major. And then the floor, which is between these 2 majors, will be the insertion point for what we call latissimus dorsi. Latissimus dorsi. So that is one thing that you know. Now again, if you look at it, laterally, because the greater tubercle is laterally oriented. If you look at laterally, yes, closer to the mid shaft of the humerus. Okay, what will happen is that we find the insertion point to the what we call the deltoid muscle. Deltoid muscle. Now exactly opposite to the insertion point of deltoid muscle. Okay, as you can see. Okay, medially will be the insertion point to what we call the coracobrachialis muscle. Coracobrachialis muscle. Now, what happens is that anteriorly, anterolateral, anteromedial aspect, or you can simply say anterior aspect of the lower shaft of the humerus provides, origin to what we call the brachialis muscle, the workhorse, okay, of the upper limb, brachialis muscle. Okay, so that is what we find. Now, specifically, the question was talking about the origin of what we call the medial head of the triceps brachii muscle. Talking about the spiral groove, yes. So the spiral groove at the posterior aspect, we tend to see the spiral groove, running this way. Now, above the spiral groove becomes the origin for what we call the lateral head of triceps brachii muscle. And then below it, yes, we have the origin for the medial head. So that's why the medial head is the largest head. Yes, very vast origin. Okay, below the spiral groove and not above the spiral, because above the spiral groove is actually the origin of what we call the lateral head. Okay, then of course we know that the long head will be coming from, of course, the infraglenoid tubercle, which tends to overshadow this medial head, so we tend not to see it so much over here. So that is what we want you to actually know over here. Again, if you just to talk about some origin and insertion point, if you look at the distal aspect of the humerus, what happens is that we know that the medial epicondyle, which is a very palpable portion which goes oriented in the direction of the head, yes, medial epicondyle, becomes an important point of origin to what we call the anterior compartment of the forearm muscles. Okay, the flexors. So it's a common flexor origin. But apart from that, yes, what we have, what we call medial supracondylar ridge, becomes origin to what we call the humeral head of what we call the pronator teres muscle. Okay, then if you look at the lateral epicondyle, because yes, the extensors of the forearm are going to take origin from here, yes, we also call it the common extensor origin, muscles of the posterior compartment of the forearm. Then when you go to the lateral supracondylar ridge, yes, there are 2 main muscles which are going to originate here. And these muscles, yes, they are also muscles which we call them, which are part of the posterior compartment of the forearm muscles. The proximal aspect, yes, provides origin to what we call the brachioradialis muscle, and then the distal aspect provides origin to what we call extensor carpi radialis longus. Now remember that extensor carpi radialis brevis will rather be taking origin at the lower, at the what you call the common extensor origin. For the longus, it will be coming from a higher point. Okay, so that's what we see. Yes, so these are the things that I want you to know, that yes, the medial head rather originates below the spiral groove, while the lateral head, yes, originates above the spiral. So if you look at it, yes, this one oriented in the direction of the greater tubercle, that's why it's lateral, and this one you can see majority in the direction of the head. All right, so if you look at it now, this artery, which of course will be coming either directly, if it is the left subclavian artery, that one will be coming directly from the arch of aorta, but if it's a right, then it will be a branch of the brachiosacral trunk. Okay, now what happens is that with the help of a muscle, which we call it the scalenus anterior muscle, then we are able to divide it into 3 parts. Okay, so we are interested in the proximal part. The proximal part, this one goes up, okay, goes through what we call the transverse foramina of the upper 6 cervical vertebrae. This is what we call the vertebral artery. And then of course, yes, we have another one, which of course we call the thyrocervical trunk. Okay, and then opposite to, of course, the thyrocervical trunk, going deep, okay, to where we have the breast region, the thoracic region, will be the internal mammary artery. Remember that the question said internal mammary artery, which is synonymous to what we call internal thoracic artery. So please get to know that. Yes, of course, if you look at the thyrocervical trunk, then it will give what we call the suprascapular, okay, suprascapular branch. Then of course it will give the transverse cervical. Then of course it will also give the inferior thyroid artery. So these are the things that you should know. So that's a very true statement. Then if you look at the question talking about the cutaneous innervation, of course, of the hand, the dorsum, and of course the palmar aspect of the hand and ligates. Okay, if you look at it now, this is the median nerve. Now the median nerve gives a palmar cutaneous branch only. It doesn't give a dorsal cutaneous branch, and that is why it's able to supply, yes, of course, all these, this palmar area, palmar aspect 3.5, okay, lateral 3.5 of the palmar area, together with, of course, the digates. Apart from that, also the cleft spaces that we find over here, yes, they are all supplied by, of course, the the median nerve. So up to the lateral, so it's supplying the lateral 3.5 aspect of the palmar aspect of the hand, as well as the digates. Okay, so just only what we call the lateral half, okay, palmar aspect of what we call the ring finger, which is supplied by, of course, the median nerve. The medial aspect will not be supplied by the median nerve, because there will be a branch which we call the palmar cutaneous branch of the ulnar nerve, okay, which will all supply that side, as well as, of course, the pinky or the little finger. So it's simply, yes, it is only the palmar cutaneous branch, okay, which is given by the median nerve, and therefore supply, of course, the palmar aspect of the lateral 3.5 of the palm area, as well as the digates. But the surprising thing is that apart from supplying these areas, this median nerve, yes, will also give supply, okay, to the corresponding nail base area. Okay, so it means that if I want to remove, of course, the nail of this index finger, then the nerve for me to anesthetize will be, of course, the median nerve, or for the palmar cutaneous branch of the median nerve. I have to anesthetize it. Yes, likewise, if it is the middle finger, yes, the same. Yes, if it is the thumb, yes, the same. But if it is what we call the ring finger, yes, if I anesthetize the median nerve, it is only the lateral half of it which will be, yes, receive the numbness. The medial aspect, okay, I have to block that of the dorsal cutaneous branch of the ulnar nerve, because apart from the ulnar nerve giving a palmar cutaneous branch to supply the palmar aspect as well as the digates, okay, of what we call the medial 1.5 aspects of the digate, it also supplies the corresponding aspect of what we call the medial 1.5, okay, dorsally. Okay, so similarly, because it gives a dorsal cutaneous branch. Okay, so that is what we have to see. But one thing is that we saw that it was only the palmar cutaneous branch which came from the ulnar nerve to supply the lateral 3.5 aspect of the digates. Okay, palmar aspect. Then the dorsal aspect, excluding the nail beds, will be coming from, of course, a superficial branch of the radial nerve, because that one has cutaneous supply. So that is what you have to actually know. So it means that if I have to actually remove the nail bed of, for instance, the ring finger, then I have to anesthetize both what we call the superficial, I have to anesthetize what we call the dorsal palmar branch, okay, of what we call the ulnar nerve. Then apart from that, I have to also anesthetize that of the palmar cutaneous branch of the median nerve. So that is what I want you to actually know. Yes, similarly, whatever I illustrated there, yes, is summarized over here as such. So as you can see, this is the lateral 3.5, okay, of the digates, okay, as well as the palmar aspect of the digate, yes, will be coming from, of course, the median nerve. If you look at so including the nail beds, so you can see there is yellow and there is also yellow. But excluding the nail beds, the dorsal aspect, okay, of the lateral 3.5 digates, okay, as well as the dorsal aspect of the hand will be getting the supply from the superficial branch of the radial nerve. But the interesting thing that we find is that both the palmar aspect and dorsal aspects of the digate and the palm area, yes, will be getting the supply, okay, medial 1.5 will be getting from both what we call the ulnar nerve, because the ulnar nerve will give not only a palmar cutaneous branch but also a dorsal cutaneous branch. So let's move on to question number 2, and question number 2 says, which of the following is false? Now option A says a knife injury to the neck which affects the upper trunk of the brachial plexus will have possibly injured the fibers from ventral rami of C5 and C6 spinal nerve root values. Yeah, that's a very true statement, because of course if the injury happened to the upper trunk, then it was very close to its origin, because it originates from C5 C6 ventral rami. So that's a true statement. Option B says the posterior cord of the brachial plexus will lead to loss of functional rules of the suprascapular, radial, and thoracodorsal nerves. Now, there's a wrong statement. Yes, the reason is that, yes, of course, we know that the posterior cord of brachial plexus, if there's injury, it will affect, the star, including the radial nerve, no problem, thoracodorsal nerve, no problem. But it is not suprascapular nerve, because suprascapular nerve will be coming from the upper trunk of the brachial plexus, okay, as well as nerve to subclavius. Because yes, all these things, it is rather the subscapular, upper and lower subscapular nerve than perhaps wanted to say, but not suprascapular nerve. So this one makes the statement wrong. So these are the things that where we catch you, okay, because we try and then make the questions quite interesting, okay, so that you can follow through. Okay, so you have to really understand some of these things before you'll be able to answer, yes, most of these questions. So in this question, this is the correct answer, because this is the wrong statement. This is the only thing that makes it wrong. Now let's move on. Option C says injury to the axillary nerve will lead to the inability of the acromial fibers of the deltoid muscle to cause flexion of upper limb at the shoulder joint. So this is also a wrong statement. Yes, it appears to be correct, but it's a wrong statement. The reason is that, yes, of course, we know that the axillary nerve, apart from supplying, of course, the teres, minor muscle, will also supply, importantly, this deltoid muscle we are talking about. But what happens is that, therefore, if there's injury to the axillary nerve, then of course there will be weakness in the deltoid muscle. But look at what happened. It says that it will lead to the inability of the acromial fibers. Now you know that the deltoid muscle will have 3 fibers, anterior, middle, and of course posterior fibers. Now the acromial fibers, okay, are the middle fibers of deltoid. The anterior fibers are the clavicular fibers. The posterior fibers will be what you call, coming from the spine, okay, the spinal fibers, okay, coming from, that kind of spine of the scapula, okay. So this, making this one acromial fibers makes it wrong. Rather, if there's acromial fibers, mentioned, then what will happen is that loss of abduction beyond 15 degrees, okay. So that should have been the thing, because the question should rather have said that inability of what we call the clavicular fibers. That would have been a correct statement, because clavicular fibers will be important in flexion as well as, of course, medial rotation of the upper limb at the shoulder joint. So this is also a wrong statement. So both of these B and C are correct regarding this, because they are the wrong statement. Option D says the musculocutaneous nerve gives motor supply to the coracobrachialis, biceps brachii, and the medial two tiers of the brachialis muscle, and then becomes the lateral antebrachial cutaneous nerve. That's a very true statement. Now, one thing is that the name musculocutaneous nerve, yes, it is a mixed nerve because it's carrying both motor, fibers as well as sensory fibers. So the musculocutaneous, the muscular aspect will be supplying these muscles, the BBC muscles, yes, coracobrachialis muscle, bicep brachii muscle, and of course, majority of the fiber, the medial two tiers of what we call the brachialis muscle. Okay, then beyond that, yes, it becomes what we call lateral, cutaneous nerve of the forearm. Remember, antebrachium, synonymous to the word, forearm. Okay, so that is, correct. So now option E says, while the median nerve passes through the two hairs of the pronator teres, the ulnar and deep branch of radial nerves pass respectively through the two hairs of flexor carpi, yes, ulnaris and spinator muscle respectively. So that's actually a very true statement. Okay, so what you should know, these are very important questions you should understand. If you talk about the median nerve, yes, it will actually go through these two hairs, and these two hairs are, of course, the pronator teres. Okay, the pronator teres will have, of course, a humeral head and, of course, ulnar head to go through it. Then, of course, if you look at the ulnar nerve will be going through flexor carpi ulnaris, flexor carpi ulnaris. So the name ulnar head going through flexor carpi ulnaris. Then, of course, the radial nerve will be going through, of course, the supinator, muscle. So that's a true statement. So if you are going to justify, yes, the options that we saw, then what happens is that if you look at, the brachial plexus is coming from C5, C6, C7, C8, and T1 ventral rami of the spinal nerves. Okay, so this way, but of course we already know that there could be, a prefix brachial plexus where, of course, it will start from C4 and end at C8, and then there could be a postfix brachial plexus which rather begins at C6 and ends at T2. So please know those kind of anatomical variations that we have. They are very common phenomenon that we've seen. But the question says an injury, okay, a knife injury to the upper trunk. Okay, if there's injury over here, then what will happen is that perhaps if it went a bit deeper, yes, it could have also affected the C5, C6. Okay, so that is what we are talking about. Okay. And then, of course, brachial plexus, I've done it times without number, so please, you can get all those videos. But one other thing too that you have to actually know is that if there is injury to, of course, the posterior cord of the brachial plexus, then the nerves, okay, that may be affected. Yes, the mnemonic star. Okay, so the star represents the upper and lower, S for subscapular nerve. Okay, so upper and lower subscapular nerves, okay, will be affected. Okay, then, of course, the intermediate subscapular nerve, which, of course, yes, it's actually the thoracodorsal nerve, yes, will also be affected, as you saw. Okay, then A for, of course, axillary nerve. Okay, so, of course, radial nerve will be affected, yes, as well as, of course, the axillary nerve. So please get to know that it is not the the nerve to subclavius or the suprascapular nerve, because suprascapular nerve will be coming from what we call the upper trunk of the brachial plexus. So the suprascapular nerve as well as, of course, nerve to subclavius. That's where they will be coming from. So please get to understand these ones. So just by way of giving you some information, if you look at the deltoid muscle, yes, we know that it's going to originate from three main areas. Of course, from the superior surface of the lateral thread of clavicle, so from clavicular head, some be coming from the acromion, so acromial head, and some from the spine of the scapula. But here it goes and inserts on the deltoid tuberosity on the humerus. Then it is supplied by, of course, the axillary nerve, just like the other muscle which we call the teres minor muscle. Okay, But what we find is that it is the acromial fibers, okay, acromial fibers, okay, which will be very important in abduction. That is the middle fiber that we are talking about. Will be very important in abduction. Abduction beyond 15 degrees, so 15 to 90 degrees abduction. But of course, the middle fibers of deltoid, also called the acromial fibers. Then the spinal fibers, okay, will be coming from, of course, the spine of the scapula, and that one will be very, because it's more posterior related, it will be important in extension, okay, as well as lateral rotation, okay, of the upper limb at the shoulder joint. Okay, so please get to know that. Yes, by way of giving you some information, because teres minor is also supplied, but of course, this axillary nerve, which goes actually through what we call the quadrangular space, together with, of course, the posterior circumflex humeral artery. Yes, we are looking at it. Then teres minor will be coming from, of course, that area, lateral margin of what we call the infraspinal fossa. But actually, it's coming from, of course, the lateral border. So please know that the lateral border of the scapula is known for, origin generally. Then to be inserting on, of course, what we said, the inferior most, facet on the greater tubercle of the humerus, one of the 6 muscles, rotator cuff muscles. Yes, and then because of its location, it will be very important in lateral rotation. It's also assisting in, maintaining the head of the humerus, in its, that kind of shoulder joint, in the cavity, glenoid cavity, during, that kind of abduction. So please, that is what you should know. So there we are, just to show you some bit more. Yeah, this is what we call the clavicular head. This is the deltoid muscle, full extent, but this is actually showing you more anterior aspect. This is the clavicular head. And therefore, this clavicular head, because of its position, yes, upon contraction, it will help inflection. Apart from that, even medial rotation at what we call of the upper limb at the shoulder joint. Okay, so this is the clavicular fibers, or the anterior fibers of the deltoid muscle. Then we also have what we call the middle fiber. The middle fibers will be coming from the acromion of the scapula. And what that one, okay, now one thing too that you should know is that out of all these 3 fibers you are talking about the deltoid muscle, it is only the middle fibers which show this kind of multipinnate. Anterior and posterior fibers are unipinnate. Okay, so this multipinnate middle fibers of deltoid, yes, will be coming from the acromion, and of course, what they will be doing is to assist in what we call propagation of abduction, okay, of the upper limb at the shoulder joint, going beyond 15 degrees, so 15 to 90 degrees, not 8 to 15, it is actually 15 to 90 degrees, 0 to 15 degrees by, of course, the supraspinatus muscle. I've done all these videos, please get them so that you can really understand what we are doing. Then if you look at the posterior aspect, this is the posterior view. If you can see, that will be the spine, okay, of what we call the scapula. And taking origin there will be, the posterior fibers, or the spinous component of what we call the, deltoid muscle. And that one, because of its, position, it will be important in, that kind of extension, and of course lateral rotation of the upper limb at the shoulder joint. So please get to understand these things. Yes, again, we said that we have the musculocutaneous nerve, which has both the motor fibers as well as sensory fibers. So what happens is that, yes, there is this nerve which comes from the lateral quadribrachial plexus, which we call it this musculocutaneous nerve. Okay, this nerve pierces this muscle, which we call the coracobrachialis muscle. Okay, coracobrachialis muscle, and therefore after piercing it, yes, it runs through, yes, between, of course, the biceps brachial muscle superiorly, and of course the brachialis muscle inferiorly. Okay, because these are the muscles of the anterior compartment of the arm, yes, they are supplied by that's why it will be related here. So as it pierces it, it supplies it. Then as it comes over here, it gives some branches to supply the biceps muscle, as well as, of course, the medial to two tears of what we call the brachialis muscle. But what happens is that just about 2 centimeters, around 2 centimeters above this elbow joint, that is where it terminates, and then it becomes what we call a cutaneous nerve only. It becomes a lateral cutaneous nerve of what we call the forearm. Okay, so please get to know that lateral cutaneous nerve of the forearm. So let's go to our last question for this revision, and that is question number 3, and it says, which of the following is not true? Option A says downward displacement of the head of the humerus will likely cause injury to the axillary nerve and thus loss of cutaneous sensation to the superior lateral aspect of the arm. That is a very true statement. The reason is that, yes, running through the quadrangular space is the axillary nerve, and it is the axillary nerve which will be, apart from giving motor supply to, of course, the deltoid muscle as well as teres minor muscle, it also has some cutaneous innervation, okay, to give and to supply that kind of superior lateral aspect of what we call the arm, okay. Now, one thing is that I told you the last time that, yes, the shoulder joint is the frequently dislocated joint in the human body. Yes, it tends to have an inferior displacement because inferiorly it is a bit, deficient, regarding, the joint capsule. Okay, when there's that kind of, inferior or lower displacement, then the likely nerve, okay, will be injured, okay, or that will be involved in the situation will be the axillary nerve. And the axillary nerve not only supplies the deltoid and teres minor, but also give cutaneous supply to the superior or the upper lateral aspect of the arm. That's a true statement. Option B says if a patient can abduct the arm at the shoulder joint beyond 15 degrees but fails to initiate it, then there's likely injury to the long thoracic nerve. That's a wrong statement. Yes, you may have a patient who can abduct the shoulder joint beyond 15, the arm, okay, at the shoulder joint beyond 15 degrees. It means that there's no problem with, of course, the deltoid muscle, because the deltoid muscle being important in doing that, because this nerve, which is called the axillary nerve, is intact. But this patient fails to initiate it. So 0 to 15 degrees, I told you, will be coming from, of course, this supraspinatus muscle. And of course, this supraspinatus muscle, yes, is supplied by, of course, the suprascapular nerve. Okay, so that not rather long thoracic nerve, but rather suprascapular nerve. If rather there's injury to long thoracic nerve, it will lead to what we call ringing of the scapula, basically medial ringing of the scapula. Okay, that's what we will see. So this is the wrong statement. So already we've seen our correct answer. That is option B. But let's move on. Option C says movements that are likely diminished in injury to the suprascapular nerve at its commencement may include lateral rotation. Yeah, that's a very true statement. Although there will not be loss of lateral rotation, but it will get diminished. Okay, because of course the suprascapular nerve, apart from supplying the supraspinatus muscle, also goes on to supply what we call the infraspinatus muscle. And infraspinatus muscle is one of the lateral rotators of what we call the upper limb at the shoulder joint. So that's a true statement. Okay, so we will justify these ones. Now, option D says tennis elbow may affect 6 muscles, namely extensor carpi radialis brevis, extensor carpi ulnaris, yes, extensor digitorum, and coneus, and the spinator, muscles. Yeah, these are the important muscles which, of course, yes, it will, tennis elbow may affect. Okay, so that is a very true statement. Tennis elbow may affect these ones. Option E says the medial epicondyle provides origin directly to only 4 muscles in the anterior compartment of the forearm. Yes, you will see that some books may say 5, but you will see why we are saying it's 4. So that's a very true statement. Let's justify these ones. So there we are. This is the shoulder joint. Okay, this is the shoulder joint, and that nerve which goes through the quadrangular space and winds around the surgical neck of the humerus. And for that matter, if there's fracture, okay, of the surgical neck of the humerus, this nerve, which we call the axillary nerve, will be involved. Okay, but we are talking about the inferior dislocation of the shoulder joint. So as you can see over here, then what happens is that the nerve that is likely going to be injured will be, of course, the axillary nerve, because it's the one which goes through the quadrangular space. Okay, yes, alongside of our posterior circumflex humeral artery. So there we are. If there is injury, okay, downward displacement of the humerus, as we've seen, okay, or if there is injury of the axillary nerve at the cervical neck of the humerus. Then apart from the muscles wasting, which I will show you a picture, okay, so there will be wasting or paralysis of the deltoid muscle, as well as of course the teres minor muscle. Okay, but importantly, what regarding this question is the cutaneous innervation. So there will be numbness over here, upper lateral aspect of what we call the of the arm. Okay, so this area there will be loss of cutaneous supply. Yes, no, the patient will not be able to feel anything over here. So that is what we are saying. If you look at the axillary nerve from C5, C6 coming from the posterior quadribrachial plexus, yes, we said it's going through the quadrangular space and it winds around the cervical neck, alongside the posterior circumflex humeral artery. Okay, therefore importantly these areas, okay, if there's injury, inferior dislocation of the shoulder joint, okay, or fracture of the cervical neck of the humerus, then it is going to be affected. Then when it's affected, we said there will be cutaneous loss. Apart from that, this muscle over here, deltoid muscle, as well as teres, minor muscles will be affected. So you can see a patient showing wasting of the deltoid muscle because of course injury to of course the axillary nerve, and for that matter, yes, there will be numbness as well over here. Now we talked about a question, and then the question talked about the fact that if a patient cannot abduct the arm, okay, at the shoulder joint beyond 15 degrees, then the nerve that is likely in the long thoracic. No, it's not long thoracic nerve, because this long thoracic nerve that you find over here, okay, which runs along the lateral aspects of the thoracic cage, thoracic wall, actually will be supplying these digitations. Okay, the muscle, the boxer's muscle, that is serratus anterior muscle. Serratus anterior muscle. If serratus anterior muscle is actually injured, okay, remember that long thoracic nerve will be coming from C5, C6, and then C5, C6, and of course C7 root values, and then run along the lateral wall of what we call the thoracic cage of the thorax actually. Now let me show you, if there is injury to the long thoracic nerve, okay, that injury could happen in the posterior triangle because to be coming, okay, directly from the roots. Okay, long thoracic nerve is coming directly from the roots, just like dorsal scapular nerve. Okay, therefore if there's injury to the posterior triangle of the neck, okay, that is where the roots are, then it may be injured, knife injury, something like that, or there's injury, okay, from radical mastectomy, okay, or there's injury to the chest wall generally. Then what will happen is that nerve, when it gets injured, then of course there will be weakness in serratus anterior muscle. Okay, it may become paralyzed. And when that happens, the serratus anterior muscle is the important muscle which maintains the medial border of the scapula, intact. Okay, when that happens, okay, there will be what we call difficulty in overhead abduction, because overhead abduction, apart from this trapezius muscle, yes, also the serratus anterior muscle is also doing that. Overhead abduction, abduction beyond 90 degrees. Okay, now when there is winging of the scapula, and that one is due to paralysis of serratus anterior because of injury to long thoracic nerve, then what happens is that the medial border becomes pronounced, as well as the inferior angle. Very important. Some people fail to mention the inferior angle. Yes, you have to remember that. Okay, now having talked about winging of the scapula, then one other thing that you should know, yes, apart from, yes, if you say winging of the scapula, yes, then the muscle involved is of course the serratus anterior muscle because of injury to long thoracic nerve. But sometimes when there is injury to the spinal accessory nerve, okay, where is cranial nerve 11, then what happens is that, yes, it may lead to paralysis of what we call the trapezius muscle. Because the trapezius muscle, if there's injury, it will lead to what we call lateral winging of the scapula. Lateral winging of the scapula. So anytime you hear lateral winging of the scapula, think of trapezius. If you hear medial winging of the scapula, think of the serratus anterior muscle. But generally, if they just say winging of the scapula, then go for, of course, serratus anterior muscle. However, if the patient cannot abduct, okay, at what we call abduct the arm at the shoulder joint, then what will happen is that the muscle which is actually involved is what we call the supraspinatus muscle. As we said, supraspinatus muscle, its nerve supply is coming from, of course, the suprascapular nerve. Suprascapular nerve. Now remember, the suprascapular nerve actually is a content, okay, of this created, foramen over here. Because we have this kind of superior, suprascapular, ligament over here. Okay, this ligament over here creates, there's a notch over here, which of course, will be, bridged by this ligament, suprascapular, ligament, or transverse scapular ligament. Okay, so over here, now what happens is that the artery, rather, where the suprascapular artery, goes above it. So if there's injury of the nerve at its commencement, where it begins, then of course, yes, suprascapular, this muscle, supraspinatus muscle, as well as, infraspinatus muscles, both will be affected. Both will be affected. When that happens, then what will happen is that there will be loss of initiation of abduction. You can't abduct because the supraspinatus muscle is for 0 to 15 degrees abduction, okay, of the arm at the shoulder joint. Then infraspinatus muscle will be important in what we call lateral rotation, helping in that kind of lateral rotation of the arm at the shoulder joint. So if you are seeing such a phenomenon, okay, this one will not be lost. Yeah, lateral rotation will not be lost, but of course initiation of abduction will be lost completely, because that's the only muscle which of course will help in initiation. Okay, because of course lateral rotation, even teres minor will help in that one, yes, to do that. Okay, even if you look at something like pectoralis major, okay, will help assist in that kind of movement. Okay, actually. So pectoralis major will assist in actual medial rotation. So for instance, something like teres minor, yes, will be lost. So what happens is that there will be diminished lateral rotation, diminished, not completely lost actually. So what I'm trying to say is that the injury could happen, yes, over here. There could be entrapment, okay, over here in this notch created. For instance, if there's any cyst over here, if that injury happens over here, then both supraspinatus and infraspinatus muscle actions will be lost. But if it happens over here in the spinal glenoidal notch, okay, then what will happen is that, yes, that kind of injury, what will happen is that the nerve got injured over here. Therefore, the muscle over here, where is the supraspinatus, will be spared. Okay, so the patient can abduct, but there will be diminished what we call lateral rotation of the arm at the shoulder joint. So please get to know that. Now, if you look at, those kind of 6 muscles that we find over here, yes, which are, actually taking origin from, of course, the lateral epicondyle. And therefore, when there is lateral epicondylitis, which of course we call tennis elbow, if you are using your extensors a lot, yes, then these muscles which are actually attached over here may be affected. And therefore, yes, these muscles, yes, we have what we call extensor carpi, radialis brevis. Okay, extensor carpi radialis brevis will be gone. Yes, extensor digitorum, likewise, extensor, digiti minimi, yes. And then of course extensor carpi ulnaris. Okay, so these are some of the muscles, yes, apart from that, even anconeus, and of course the spinator muscles. So if you want to count them, yes, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi. Yes, if you look at extensor carpi ulnaris, if you look at anconeus, and then of course if you look at spinator muscles, they are actually 6 muscles which will be affected directly in tennis elbow. So that is it. If you continuously use your extensors, then those superficial muscles mainly, yes, taking attachments, okay, originating from what you call the lateral epicondyle, yes, will be affected. For instance, lateral epicondylitis. However, there are only 4 muscles, yes, although some books so I've justified these ones, yes, 4 muscles if there is medial epicondylitis, which we call the golfer's elbow. So if you're doing a lot of these golf actions, then what will happen is that, yes, those muscles which originate from what we call the medial epicondyle, yeah, may be affected. Okay, so those muscles, yes, we are saying there are 4, and these muscles, yes, they are what we call the flexor carpi radialis, palmaris longus, flexor carpi ulnaris, okay, and then of course flexor digitorum superficialis, not pronator teres. Although some books will add pronator teres, but pronator teres is actually not coming from medial epicondyle, but actually from medial supracondylar ridge. Medial supracondylar ridge. So these are muscles of the anterior compartment of the forearm. Therefore, of course, it makes sense. Most of them superficial ones will be coming from, of course, the medial epicondyle. Alright, I'm very grateful for your time this evening. I hope you find this revision exercise helpful. Please learn alongside, even though you are, on vacation. What happens is that you don't need to stop learning. I believe, you are doing well. Have a good night, and may the good Lord richly bless you. Amen.